Good evening, everybody, and welcome and thank you for joining this webinar on the QUIPP App and how it can help triage women in threatened preterm labour. My name is Jenny Dorrington, and I'm the UK Perinatal Business Development Manager at Hologic. And presenting to you this evening will be Naomi Carlisle, Senior Research Midwife from King's College London. So the agenda for today's session is going to be regarding the QUIPP App, why preterm interventions are time critical and may do harm, how the risk of preterm birth is on a continuum, being able to see how the QUIPP App can aid your decision making, find out how to implement the QUIPP App at your unit, and then at the end we'll also have time to do a Q&A session. A training certificate will be provided to all attendees. If there's a group of you viewing today on one device, please do contact us afterwards with all of the attendee names and the hospital that you are coming from so that we can do an individual certificate for all of you. So for example, if you're a group of 4 people but sharing one laptop, please do email us with the details of each attendee. If you've got any questions during the session, you can write your questions in the following ways. If you're watching on your phone or iPad, all you need to do is to tap on the screen and you will see 3 dots. On the screen, you can see it just shown here. Just click on the Q&A and then type in your question. If you're using a laptop, then just click on the Q&A button at the top right-hand side of the screen and type in your message. We're going to try and respond to all your questions at the end of the session. However, if you do have any questions that we aren't able to answer at this point, please feel free to get in touch with us. You can contact the Hologic team at ffntest@hologic.com, or if your question is specific to the QUIPP, please don't hesitate to contact the team at quipapp@gmail.com, and we'll share those email addresses at the end of the session as well. So now I'm going to stop sharing my screen and pass over to Naomi.
Hi, Jenny.
Who will take over the control. Hiya.
Thank you for that. So yes, hello everyone. My name is Naomi Carlisle. I'm a Senior Research Midwife in Preterm Birth, and from September I'll be starting my clinical doctoral fellowship. So firstly, thank you for logging in this evening, and also thank you to Hologic for inviting me to do this presentation. So I'm now going to share my screen so we can all see the presentation. Okay. So hopefully everyone can now see my screen. If you're having any issues with seeing it, then make sure that you do write in the Q&A bar like Jenny just mentioned, and we'll be able to sort that out. Okay, so I'm going to talk to you today about how the QUIPP App can help you triage women in threatened preterm labour, and also talk to you about how you can help implement the QUIPP App at your hospital. All of the slides that I'm talking about today come from the QUIPP App Toolkit group, which is comprised of myself and obstetricians Dr. Helena Watson and Professor Andrew Shannon. If you've got any questions at all, just like Jenny said, our email addresses are at the front of the screen, so you can either email me directly or you can email the QUIPP App email and we'll reply to you. Okay, so firstly, why is this an important issue? So, as probably a lot of you know, it's quite difficult to diagnose women who arrive at your unit with symptoms of threatened preterm labour. So these symptoms could be back pain or abdominal pain, period-like pains. And when women present with these symptoms preterm, so when they're less than 37 weeks gestation, it's quite difficult to determine whether they are actually going to go on into full-blown preterm labour, or if these symptoms are just going to subside. We know that over 70% of women who present with these symptoms of threatened preterm labour actually give birth at term. And we know that more than 95% of women who do present with these symptoms of threatened preterm labour don't deliver within 2 weeks of presentation. So that means that if we admitted every single woman who had these symptoms, the vast majority of them would still be sitting in your antenatal ward 2 weeks later, not having had their baby and bed blocking. So what this tells us is that symptoms alone aren't a good predictor of who will have their baby early. And as clinicians, we're not very good at diagnosing who will deliver preterm purely based on symptoms. However, it would be great if we were able to accurately diagnose who was going to have their baby early. And that means if we were able to do that, that would be able to ensure that the appropriate women were admitted to hospital, the appropriate women were sent home because they weren't going to deliver their baby early. It means that the right woman can be transferred to another unit if necessary. And it means that the only appropriate women are given steroids and other interventions. And I'm just going to talk in a little bit more detail about some of these interventions and why it's really important that we give them at the right time. So firstly, I'm going to talk about steroids. So as you know, being clinicians, antenatal steroids are a really important drug when they're given to women who are likely to have their baby imminently. Numerous studies have shown us that babies that receive steroids in appropriate timeframes have lower rates of mortality, lower rates of morbidity, less likely to have respiratory distress syndrome and CVS hemorrhage. And these drugs can save lives. However, what research has also shown us is that the benefit of steroids is actually seen just a few hours after first administration to the mother. And what we've actually seen is that the benefit of steroids actually reduces over time. So if you are giving steroids to a woman and she delivers 7 days after administration of that steroid dose, we actually know that she's not getting any of those benefits and her baby's not getting any of those benefits, which we would typically see with steroids. And that's shown really nicely in this table here, which was taken from the 2015 World Health Organization recommendations in preterm birth outcomes. So as you can see that the benefits of neonatal mortality and fetal death is only seen when they're given within the first 48 hours. Respiratory distress syndrome, that the benefits are only seen when they're given less than 7 days, and likewise for CVS hemorrhage. So what this tells us is that steroids are a really important drug, but they're only actually giving us our benefits if we're giving them within 24 hours to 7 days of that woman delivering. We know that actually, if you give a course of steroids and the woman doesn't deliver within 7 days, we're not getting any of those benefits, but actually we're doing harm, because we know that after just one single course of steroids, babies who have been given steroids in utero compared to babies who haven't been given steroids in utero have reduced birth weight, reduced birth length, and head circumference. And we've actually seen in animal studies as well that it may affect neurodevelopment. So I think what our take-home message from this slide really is that steroids are a really important intervention and they do save lives, but we should not be giving them as a blanket approach. The timing of steroids is really important, and even if we just give one course of steroids, we can actually end up doing quite a lot of harm for that infant. In utero transfer is another really important intervention, which we quite often do in the UK. So if a woman presents at a unit and that unit doesn't have a maternal bed available for her, or doesn't have a neonatal cot available for the baby if the baby is born, or it may just be that the neonatal unit where the woman's presented at, it's not an appropriate facility because it can't care for babies at that very early gestation. It's really important that if we have a woman and we think she is going to deliver imminently and there is a reason why she needs to be transferred, that she is transferred when she's still pregnant, so in utero rather than ex utero. And that's because we know that if a baby is born at an appropriate unit, that baby has higher rates of surviving and lower rates of morbidity compared to if it's born at an inappropriate unit. And we also know that if that woman is transferred antenatally compared to once a baby's been born, that baby also has a better chance of survival. And that better chance of survival does not compromise their morbidity. So sometimes you see that mortality rates are decreased, but that's compensating because they have higher rates of morbidity. We don't see that in this case. We know that babies are born at the right unit, and ideally if they're born there rather than transferred there once they've been born, that they show higher rates of survival. And I think this really just highlights that if we are able to accurately diagnose who is likely to have their baby early and make sure then that they are in that right unit for when the woman does deliver, that we're going to get better outcomes for these women and for these babies. We also know from qualitative research that transferring a baby ex utero really impairs that fetal, that maternal bonding and parental bonding that they have with that baby. Sometimes you have a situation where a mum is in one unit and her baby is being transferred to another unit, and then you have the family who are trying to visit both the mum and the baby who are in different hospital units, and they can be miles away. And we know that those first few days and weeks that parents have with their children is a really important time to develop this bonding. But also if you think about the financial implications of the travelling, and also just the fact that this is a really stressful time in their parents' lives. They've just had a preterm baby. We don't want to add to that. So I think it's really important to think that when we accurately diagnose women and determine if they're going to deliver early or not, it does have a lot of knock-on effects for these families, and some of these knock-on effects are ones that we don't actually really realise, because by the time they've happened, they're kind of outside of our care. So this table here really just highlights all of the different interventions that we offer women and their babies when they arrive in threatened preterm labour or preterm labour. So we've got steroids, in utero transfer, both of which I've talked about in a little bit more detail, tocolytics and magnesium sulfate. And then it also just highlights the risk factors or the negative effects which are associated with all of these interventions for the fetus, for the mother, and also for the service as a whole. And I think this table really just shows us that every single intervention has side effects which are positive and negative. And it doesn't mean that we shouldn't be giving these interventions. We definitely should. And they are really important, and they do save lives when they're given appropriately. But it just shows that we shouldn't be giving this as a blanket approach. There are negative side effects to all of these interventions, and we need to be thinking about these when we're giving them to women and when we're giving them to babies. And if you'd like more information on these different interventions and the side effects of them, there's more detail in our evidence summary, which you'll be able to get in our toolkit, and I'll provide the link to that at the end of this presentation. So, what we've learned so far is that it's really important that we're able to predict who is likely to have their baby early, so we can give these interventions at the right time. So how can we predict who is likely to have their baby early? So it's really helpful if we can use predictive tests to help us when we have a woman who arrives in threatened preterm labour. And in the UK, these are the different tests which are available to us when we're looking after symptomatic women who have arrived in threatened preterm labour. So we have transvaginal ultrasound cervical length measurement, and then we also have some biochemical markers which encompass actin partus, partusure, and fetal fibronectin. And for the rest of this presentation, I'm just going to focus on cervical length and fetal fibronectin, because they're the two tests which are inputted into the QUIPP app. So it will just help if I explain a little bit more detail around them. So firstly, cervical length scanning in threatened preterm labour. So we know that the shorter a cervix is, the more likely that this woman has of delivering preterm. And the largest prospective study that we have tells us that if a woman presents and her cervix is less than 15 millimetres, that she's got a higher chance of delivering her baby early compared to if her cervix is more than 15 millimetres. And we know that that risk increases the shorter the cervix gets. So if a woman arrives and her cervix is less than 5 millimetres in length, her risk increases to 80%. We know that the negative predictive value of cervical length scanning is affected by gestation. So it's got a higher negative predictive value rate if we are using this on women who are under 32 weeks compared to women who are over 32 weeks. We know that the length that you get when you undertake a cervical length scan is going to depend on the operator who scan. So there is operator variability. And we also know, especially in the UK, that a lot of people aren't trained in how to do cervical length measurement, and quite often there isn't the equipment available to do it. So especially if you have a woman who arrives at your triage unit at say 2 AM in the morning, it's probably quite unlikely in the UK that she's going to have cervical length scanning undertaken, and it might be something which is undertaken if she was admitted on the ward round the next morning. So fetal fibronectin, I'm sure a lot of you already know what fetal fibronectin is, but for those of you who don't, fetal fibronectin is best way to think of it is almost like a glue, which holds together the fetal membranes and the maternal membranes. It's like a glue which holds those two membranes together. So it should only really be found in the uterine cavity. If you are able to detect fetal fibronectin in the vaginal cavity, it shows that there's been some sort of breakage or leakage or something, which means that perhaps this woman is likely to have her baby early. So we know that we can undertake a swab and see if there's fetal fibronectin in the vaginal cavity as a clinically validated test for symptomatic women between 22 weeks and 35 plus 6 weeks gestation. We know that fetal fibronectin has a really high negative predictive value, which means that it's a really good rule-out test. So you can be quite confident that if you have a woman who has a low fetal fibronectin result, that you can send her home and be really quite confident that she's not going to have her baby early. So fetal fibronectin, the lower the result, the less likely this woman is likely to have her baby early. And we know that if her fetal fibronectin result is under 10 nanograms per milliliter, that is a very, very low result. Hospitals have traditionally used a cutoff of 50 nanograms per milliliter. So if you had a fetal fibronectin result which was under 50, it would be considered a negative test. And if it was over 50, it would be considered a positive test. More sites now are using a cutoff of 200 nanograms per milliliter, and I'll explain the rationale for that in the next slide. I know a lot of hospitals like to have a cutoff, especially when they're triaging women who arrive with symptoms of threatened preterm labour, but I really would try and encourage you to think of preterm birth risk as a continuum. It's not as simple as saying that a woman's risk of preterm birth, is really low if she has a result of 49 or of 199, and this woman's risk is greatly increased if she has a fetal fibronectin result of 51 or 201. It's not as simple as positive and negative. We know that her risk increases as the fetal fibronectin increases, and we know that her risk decreases as the fetal fibronectin result decreases. That can sometimes be quite hard to sort of manage in your head, and this is where the QUIPP app comes in, because the QUIPP app enables you to think of that woman's risk as a sort of continuum, but also think of the woman sort of holistically, and puts it all together for you in a kind of easy to manage format. But we'll come on to the QUIPP app later on in this presentation. So on the last slide, I mentioned how some sites use 50 nanograms per milliliter as a cutoff, and some sites are now using 200 nanograms per milliliter as a cutoff. And we get quite a few emails to the QUIPP app email saying what is the rationale for this and what should our hospital use. And if that's you, then this is the slide for you. So this slide here is showing data from our group, which was published back in 2013. And it's showing the negative predictive value of fetal fibronectin with the blue columns and the positive predictive value of fetal fibronectin with the purple columns. And as you can see, the negative predictive value of fetal fibronectin at 50 nanograms per milliliter is 96.8. If instead you use a cutoff of 200 nanograms per milliliter, your negative predictive value is decreasing slightly to 95.8, but you're gaining quite a lot in positive predictive values. You're going up from 31.8 to 61.1. So what that's basically telling you is that if you use a cutoff of 200 instead of 50, you're not losing a lot of your negative predictive value, but you're gaining a lot in your positive predictive value, which means that you're going to triage women better. So that's why hospitals are now kind of moving to this 200 nanograms per milliliter. But like I said before, I would really encourage you to not think of it just simply as sort of a black and white cutoff, but do think of preterm birth on a continuum. And this is where the QUIPP app comes in. So the QUIPP app. The QUIPP app is free to download on Apple and Android. You just need to search QUIPP either on iOS or on Google Play, and it will come up. There's also a website version available at www.quipp.org. So the QUIPP app is basically a decision support tool that gives you an individualized score for the woman that you're looking after for her risk of having a spontaneous preterm delivery. And it does that by incorporating the woman's medical history, her fetal fibronectin result, and or her cervical length, combining it all together and giving you a result. There are 3 separate algorithms to the QUIPP app. There's the fetal fibronectin algorithm, the cervical length algorithm, and the fetal fibronectin and the cervical length algorithm combined. So as there are 3 different algorithms, it means that you can use the QUIPP app either having just fetal fibronectin or both fetal fibronectin and cervical length, or just cervical length. Because there are 3 different algorithms, it means that say if you were inputting a woman into the app and you were just using fetal fibronectin, you didn't have a cervical length measurement, you're not losing anything. And that's because if you were just using fetal fibronectin, you'd then go onto that fetal fibronectin algorithm. And then all of the other different risk factors which help make up her risk score take different weights to compensate for the fact that we're just using either one test or 2 tests or another test. So don't feel that you shouldn't use the QUIPP app or you can't use it if you only use fetal fibronectin in your unit. You definitely can, and it doesn't affect the predictive ability of the app, because it just means that the different risk factors take different weighting in the final result. With the QUIPP app, we use the actual concentration of fetal fibronectin. So we're not bothered if it was positive or negative or over 50, under 50, over 200, under 200. We don't care about that. We would like the actual concentration of the woman's fetal fibronectin result. And that's great because it means that we don't have a cutoff. So it means that we really are looking at a holistic assessment of this woman, because we're combining her medical history and her exact concentration of fetal fibronectin to give you the most accurate result. Lastly, the QUIPP app is a decision support tool. So while it can help you make a decision about what to do with this woman who's in your care, it's not there to tell you what to do. It's not a dogmatic tool. And we really would encourage you to use this to aid your clinical judgment. We definitely don't want to tell you what to do or take away from your clinical judgment. That's definitely not what the QUIPP app is about. So this is what the interface of the QUIPP app looks like. So you can see on the first screen that it's got all of the different questions that the QUIPP app will ask you when you open it up. And you can see that there's 8 questions, so not many questions at all. Once you've inputted all the results to those questions, it will then come up with the results, which is on the second screen. You can see at the very bottom of the screen that it says symptomatic, asymptomatic, and information. So today, obviously, we're talking about women who are arriving in threatened preterm labour. So we're only really interested in the symptomatic arm of the QUIPP app, and that's what we're talking about today. However, there is an asymptomatic arm, and you can definitely use that. And if you want more information on that, then please do just email us. So if we look at the questions that the QUIPP app asks you when you are using it for a woman who's arriving with symptoms of threatened preterm labour. So the first question is, symptoms suggestive of abnormal or premature uterine activity, and you would click yes, because that's why you're using this app. This woman's arrived and she has symptoms of threatened preterm labour. Previous cervical surgery, yes or no. Previous preterm birth, under 37 weeks, yes or no. Previous premature pre-labour rupture of membranes, yes or no. Number of fetuses, because you can use this app on singletons and twins. It's been validated in both, so you just click whatever the woman is carrying. The woman's current gestation today, and you put that in weeks and in days. The cervical length measurement, if you have it, but as I've mentioned before, if you don't have it, that's fine. If you don't have the cervical length measurement, don't enter 0, don't enter an average, don't enter a result from 2 weeks ago, just leave it blank. And then lastly, it asks you the fetal fibronectin results, and it's asking you for the exact concentration of fetal fibronectin. So once you've inputted all of that, you just press calculate at the bottom of the screen, and then that's when it will come up with your second screen. So it will tell you the risk of this woman having her baby early for 30 weeks, 34 weeks, 37 weeks, but then also within 1 week, 2 weeks, and 4 weeks. And what we are sort of most interested in, especially when you're dealing with a woman who's arrived in threatened preterm labour, is her risk of delivery within 1 week. And that's because that's the nearest time frame. And this is the time frame which will help you decide, do I need to admit this woman or do I need to send this woman home? So if we think back to the risk score that it gives you within 1 week of delivery, so if we go back a screen, you can see that, for example, on this screen, it tells us that for this woman, her risk of delivery within 1 week is 1.1%. So if you're just dealing with that 1 percentage number, it makes life a bit easy for you as a clinician. So instead of having to think about her individual risk factors and her fetal fibronectin result and how many weeks gestation she is, all you need to think about is that 1% risk score that you've been given, her risk within 1 week. So we would recommend that if the woman's risk is less than 5% of delivering within 1 week, that you can send this woman home. She doesn't need interventions. She isn't going to deliver imminently. If the woman's risk score is 5% or more within 1 week, then that's when we would recommend admitting her, giving her steroids, transferring her to another unit if necessary. We came up with this management guidance from something called a Delphi consensus study, which basically meant that we brought together a group of experts, world-leading experts in preterm birth, and we asked for their sort of consensus opinion on what they thought would be an appropriate management guidance, and they came up with the 5% risk threshold. However, this is definitely a guidance. It's not dogmatic. It's not telling you what to do. And if you have a woman who has a risk of 4.5% and you want to admit her, of course you can. That's completely up to you as a clinician. This is just here to guide you. And we find that it's most helpful for junior doctors when they're sort of triaging a woman in the middle of the night. And if you're a bit more confident in looking after women that have symptoms of threatened preterm labour, you might find actually that you're more confident, going with your own clinical acumen rather than following this guidance completely, and that's fine. So I'm just going to go through 3 different clinical examples with you now, because I think it helps when you sometimes see something in practice and think about how it can be used clinically. So our first example is a woman named Teresa. She is having her first baby, so she's gravid 1, para-naught. She's 24 weeks exactly today, and she's carrying 1 baby. She is a smoker, and she arrives at your unit with abdo pain, and she's very, very anxious about this abdo pain. She tells you that she has had sexual intercourse in the last 48 hours. So you run a fetal fibronectin result, and it comes back as 51. So traditionally, that would be a positive result. So we input Teresa into the QUIPP app, and what we get is that her risk of delivery within 1 week is less than 0.1%. So if we follow our management guidance, we know that with someone like Teresa, we could safely send her home, knowing that she's not going to deliver imminently, she doesn't need steroids, and she doesn't need admission. If you click on any of these risk scores, then it will also bring up a visual representation of the risk, as you can see on the right-hand side of the screen, which we find is really useful when you're explaining these results to women and you're trying to involve them in their care. Sometimes if you show them the visual representation of their risk rather than just the number, sometimes women prefer that. I think this case really highlights that you can have a woman who has a sort of traditional high fetal fibronectin result, but actually her risk of delivery is really low. And I think this is the benefit of looking at a woman holistically rather than just going by sort of an arbitrary cutoff. We know that when you use the QUIPP app on symptomatic women, that over 80% of women will get a risk factor, which is less than 1%. And that's including women who have fetal fibronectin results up to 250 nanograms per milliliter. If we go back a step, you can also see that Teresa said that she was a smoker. And we know that smoking is a risk factor for preterm birth alongside anxiety and domestic violence and numerous other things. When we were developing the QUIPP app, we looked at all of these different risk factors, such as smoking. And when we put them into the app, we found that the most predictive ones were the questions that we asked at the beginning. And whether the woman is a smoker or not wasn't particularly predictive about whether she was going to have a preterm birth. So you don't need to worry about risk factors such as if she's a smoker or not, because we've already included them in the app. We've already thought of that. You'll also notice that Teresa said that she had sexual intercourse within the last 48 hours. And some of you who've been using fetal fibronectin for a while will be aware that if a woman has had recent sexual intercourse, or if there is blood on the swab, that you can sometimes get a falsely elevated fetal fibronectin result. The most up-to-date guidance from Hologic, who produce fetal fibronectin, is that if you do have a woman who has had sexual intercourse or blood on the swab, you can still run that swab. And if the swab comes back as below the intervention level for your particular unit, then you can still treat that as a negative. So for example, where I work, we use the QUIPP app. So we could use a fetal fibronectin swab on someone like Teresa, input it into the QUiPP app, and because her risk is less than 5%, then that would still be a negative. And that's something which obviously you'd need to talk about with your particular hospital unit to work out where your threshold was. Okay, so now we'll move on to the second example. So this is Angela. So Angela had a previous cervical laser treatment a couple of years ago. She's currently got a vaginal cerclage in place because at 18 weeks gestation, she had a cervical length of 22 millimeters. She's currently 26 weeks and 2 days, and she arrives in your unit with some tightening. We thought maybe it was a urine infection, so we ran a urine swab, but it's come back as negative. And we've undertaken a fetal fibronectin result, and it's come back as 70. So if we input Angela into the QUiPP app, we can see that her risk of delivery within 1 week is 1.1%. So she would be safe to send home. Again, she's not going to deliver imminently. She doesn't need steroids. She doesn't need other interventions. However, if you look at all of her risk factors, you can see that her risk of delivering within 4 weeks is 6.8%, and her risk of having her baby early before 37 weeks is 31.5%. So these risks are slowly increasing. So what this tells us is that in a case like this, while we can send her home because she's not going to deliver imminently, she's perhaps someone we'd like to keep an eye on. So perhaps we could bring her back in a week's time to the antenatal clinic and repeat a fetal fibronectin test on her and input her again into the QUiPP app and see what her result is then. And that's the really good thing about using the QUiPP app and using fetal fibronectin, is that you can get those longer term predictions, which really help you manage this woman's care. It's not as simple as just sending her home or admitting her. There's all these areas of grey in between about how we manage her care moving forward and the rest of her pregnancy. And the QUiPP app really helps you with that and helps you manage that care plan together. You also see with Angela that she had a cerclage in place. So using fetal fibronectin when a woman has a cerclage in place is strictly off-label according to Hologic, who manufacture fetal fibronectin. However, numerous studies have been published where they've utilised fetal fibronectin in women with cerclages in place. The data that we have in the QUiPP app, a lot of the women in the QUiPP app who contributed the data to the QUiPP app had cerclages in place and had fetal fibronectin results. And at the unit where I work, we would still undertake a fetal fibronectin result, even if a woman had a cerclage in place. However, this is something which might be different depending on the unit that you work in. So definitely that's something to check or to make sure that everyone who works at your unit is on the same page about. Okay, so now we're on to our third example, who is Jacinda. So Jacinda has DC-DA twins. She's 32 weeks pregnant. Her cervical length is 20 millimeters. So this would be a long cervix according to the current NICE guidance. And her fetal fibronectin result is 30. So again, that would be a low fetal fibronectin result according to NICE or according to sort of traditional cutoffs. She has arrived in our unit with backache and some tightenings. So we'll input all of her information into the QUiPP app, and you can see that Jacinda's risk of delivery within 1 week is 6.8%, so quite high. It's over 5%, and we would therefore, as a guidance, recommend that you can admit this woman, give her steroids and give her other interventions. And I think using the QUiPP app in a case like Jacinda just highlights that you can have a woman who is negative in the sort of arbitrary cutoffs that we're using for preterm birth risk, whether that's fetal fibronectin or cervical length or whatever it is. But that doesn't really reassure you because, as I said, preterm birth is on a continuum, and you need to think about the woman holistically rather than just going by her predictive tests. And when we look at a woman holistically, which the QUiPP app does for us, we can actually see that women that traditionally would have been low risk are actually quite high risk, and we should be admitting them, and vice versa. So, evidence for the QUiPP app. So, the QUiPP app is a validated tool. There are numerous studies which have been published on the QUiPP app. And if you would like any of these research papers, And if you can't access them yourself, please do just email me and I'm more than happy to ping them across to you. Currently, the QUiPP app is used all around the world. We've got app analytics where we can see where the QUiPP app is being used on which mobile devices and where they're registered. And we know that it's being used in America, Canada, India, Brazil, Australia, across Europe, numerous places. And it's also being used across the UK as well. So the data for this slide has come from the paper which was published by Jenny Cantor and Ellie Watson and numerous other people from our team in 2019. And this is talking about how accurate the QUiPP app version 2 is. So we're currently on version 2 of the QUiPP app to it and changed a few of the functions to make it a bit jazzier and a bit glossier. So version 2 is what we're on at the moment. And as you can see with this slide here, this is looking at how accurate the QUiPP app is at predicting preterm birth in women who are likely to have a baby under. And it's using the algorithm which just alone. And you can see here that it has a really good negative predictive value of 99.6. So it's a really strong, accurate predictor. The figure on the right-hand side is a ROC curve, so it's looking at the sensitivity and specificity of the QUiPP app. For those of you who aren't really into statistics, a ROC curve basically tells you how accurate the QUiPP app is. If the area under the curve is what we're interested in, so if the area under the curve is 1, it's a perfect test, and if it's 0.5, it's a useless test. It's as good as flipping a coin. So having an area under the curve of 0.96 is excellent. It just shows that it's a really accurate app, and we're really happy with these statistics. It shows that it's a validated, accurate app which you can definitely use in your hospital and feel confident and safe using it. So this slide here is from a paper which was published by my colleague Dr. Ellie Watson back in 2017. And what it's looking at is using the QUiPP app on women compared to using current NICE guidance on women. So if we go back a slide, you can see that this slide here is looking at how accurate the QUiPP app is at predicting preterm birth in women who are under 30 weeks gestation. And what this slide here is showing is that the current NICE guidance advises that if you have a woman who arrives in threatened preterm labour and she's under 30 weeks gestation, that you should admit her. You don't need to do a predictive test, just admit her, and quite often a woman's admitted and then obviously given all of the interventions which we've talked about at the beginning of this presentation. So if you had 100 women under 30 weeks and you admitted them and you followed NICE guidance because they all had symptoms and they're all under 30 weeks, you'd see that everyone would be in hospital, and that's demonstrated on the left-hand side by all the little H's. So you can see that every woman is a H because every woman is in hospital. The majority of women are hospitalised inappropriately because they don't deliver within a week, which we know. So all of those women are red H's. And you do capture the 3 women who do deliver within a week, but that's at the cost of admitting 97 women who won't deliver within a week. And that means that those 97 women have obviously been exposed to interventions like steroids, which we know are harmful and they're not providing any benefit to these women or their babies. It means that these 97 women are bed blocking because they're still going to be there a week later and they haven't delivered. But also just the effect on the woman. Women have jobs, busy lives, other children to care for. Most women don't want to be in hospital for a week if they know that actually their risk of delivering is very, very, very low, which for these women, of course, it is. If we compared these women and we, instead of following the NICE guidance, we use the QUiPP app on them, we can see that the majority of these women would be sent home. And this is shown on the right-hand side because the majority of women have a little house. They're denoted by little house. And it's a green house because they are sent home appropriately. They're sent home and they don't deliver within 1 week. There are going to be a few women who are hospitalised inappropriately. And that's almost like a safety mechanism to make sure that we do capture the women who do need to be hospitalised. But you can see that it's far fewer women. And most importantly, by using the QUiPP app, we still do hospitalise the woman who are going to have their baby early. So by following the QUiPP app in this group of women, you can see that we would have reduced 89% of hospital admissions and all of the associated risks and costs. So I think this really just highlights that the benefit that your unit could get by using the QUiPP app when triaging women who arrive in threatened preterm labour, regardless of their gestation. So if you would like to implement the QUiPP app at your unit, you can use the new QUiPP App toolkit. So this toolkit was developed very recently. We won a grant from Health Innovation Network South London late last year. And our aim was to produce a toolkit to help sites up and down the country implement the app at their unit and produce it by September 2020. However, COVID happened. And as a result of COVID happening, as you remember, everyone was quite worried about there being not enough hospital beds, about there being strain on the ambulance service. And suddenly we got a lot of interest in the QUiPP app because it helps reduce admissions and because it helps reduce unnecessary ambulance transmissions, where people were suddenly very interested and wanted to use the QUiPP app. And we had quite a high demand for people wanting the toolkit available immediately. So as a result of this, we rapidly rolled out the QUiPP app toolkit due to COVID, and version 1 went live in April of this year. So it's available on the BAPM website, and we're really grateful that BAPM were able to host this for us and endorse it. So if you just go to www.bapm.org/QUiPP, you'll be able to access all of the toolkit documents. So the toolkit documents are basically a bundle of documents, information, presentations, all different tools which we think would help you implement the QUiPP app at your hospital site. We're also at the moment offering free training to hospital sites to help them implement it. We've done this for a few different sites up and down the country via Zoom or Microsoft Teams. Some sites, they've wanted us to talk directly with their junior doctors and their midwives on the triage unit, and we can do that. Other sites have wanted us to just talk with their managers, and then they're doing cascade training. We can definitely work a solution which, you know, would fit your unit. So if this free training is something that you're interested in, please do email us and we can pencil a date in the diary. So if you go on the BAPM website, this is what it will look like, and you can see all of the toolkit resources there. The toolkit resources are also just outlined here in a bit bigger font, just so you can see exactly what the toolkit involves. We've developed a lot of feedback in trying to develop the toolkit to make sure that clinicians would find it useful and that it would be useful on the shop floor. We are currently working on a version 2 of the QUiPP app. Because we rolled out version 1 quite rapidly because of COVID, there are some extra things that we wanted to include, which we are going to include for version 2. Version 2 will be available on the same link, so bapm.org/QUiPP in about a month's time, so just keep an eye out for it. We're going to include a video in it and also some stickers so that you can print these stickers off and use them in your hospital unit for clinicians to write down the QUiPP app when they're assessing women. But if there's anything additional which you think would really, really help you implement the QUiPP app at your unit, which isn't currently in this list, and it's something which you'd really, really like, please do get in touch. Now is the time to do it because we're working on version 2. We're more than happy to get your feedback. We're continually refining it. So we want it to be a toolkit which suits you. So please do let us know if there's anything else which you think would help. So since our toolkit has been launched, it's gained quite a lot of traction. We know that it has been included in the West of England Peri-Prem bundle, and we're really pleased that it's been included in that. We also know that it's been included in the Pan-London Maternity Clinical Network group, and they've recommended it to all of the hospitals in London. And just at the end of last month, it was also included in NHS England guidance, and this is the Saving Babies Lives Care Bundle version 2, Appendix I, COVID update. And as you can see, they're recommending our toolkit on the BAPM website. So we're really pleased that all of these external agencies are recommending the toolkit and recommending the app. And we feel that this is kind of testament to how good the app is, and we really hope that your unit can get as much benefit from the app as we found in other units. So, in summary, preterm interventions are definitely time critical, and they can do harm if they're not given at the appropriate time. There's a really strong evidence base for using cervical length when assessing women, and for using quantitative fetal fibronectin. The risk of preterm birth is on a continuum, so there isn't a simple positive negative cutoff. We know that the woman's risk increases as her fetal fibronectin result increases, and vice versa. The QUIPP app is a validated, accurate tool, and it combines different individual risk factors for the woman, her cervical length, and/or her fetal fibronectin results. And you can access the QUIPP app toolkit to help you implement this in your hospital unit for free at www.bapham.org/QUIPP. So we should have time for some questions now, hopefully a lot of time for questions. You'll probably remember how Jenny told you how to ask the questions at the very beginning of the presentation, whether you're on your laptop or if you're on your mobile phone. If for some reason you don't want to ask your question in public, that's completely fine. Please do just email me, either my personal email or the QUIPP app email, which is shown on the screen here, and I'll be more than happy to talk to you via email. Perfect. So I'm just going to stop sharing my screen, and then we can go on to the questions.
Brilliant. Thank you so much, Naomi. That was so informative. We have had some questions come in to you, so I'm just going to work my way through them if that's okay.
Yeah, definitely.
So the first question that we had was, we don't do cervical length scans on our women in triage. Mm-hmm. Can we still use the QUIPP app, and won't it be less good than using it with cervical length?
Yeah, so firstly, you most definitely can still use the QUIPP app. The majority of hospitals in the UK, like yourselves, don't do cervical length scanning for women when they arrive in triage, because they're not trained in how to use it, or they don't have the equipment. So the majority of hospitals are just like your site. So you most definitely can use the QUIPP app. When you're using the QUIPP app, I don't know if you remember me explaining it in the slide, but there are 3 different algorithms for the QUIPP app. There's one where it's just fetal fibronectin, one where it's just cervical length, and one where it's fetal fibronectin and cervical length combined. And depending on what you input into the QUIPP app, it will then take you to one of those different algorithms behind the scenes. It's all complicated statistics. So if you input a woman into the QUIPP app and you've only got fetal fibronectin, you'll then just automatically be on the fetal fibronectin only algorithm. And that's fine, because when you're then inputting that woman, all of the different risk factors and questions which it asks you, the weighting of those and how it delivers your final result is different depending on what algorithm you're on. So the fact that you're on the fetal fibronectin only algorithm doesn't mean that it's less predictive than if you were using it with cervical length. It just means that there's different weightings. And actually you can see in the paper that I mentioned in a little bit more detail, Jenny Carter's paper, if you look at the predictive ability of the app for the 3 different algorithms, they're all really, really similar. And if you'd like more detail on that, then please do just email me and I can send you that paper, which has got the tables and outlines it. But in a nutshell, definitely you can use it. Majority of sites do just use it with fetal fibronectin, because the majority of sites don't use cervical length. And no, it won't be less predictive.
Brilliant. Thank you so much for that answer, Naomi. So I'll move on to the next question. So if the cutoff for symptomatic women is under 5%, or 5% and under, what would be your cutoff for your asymptomatic women?
So asymptomatic women is a bit of a different kettle of fish. And that's because it depends on what gestation the woman is, what other things are going on in her background. So I would say I wouldn't say there's a set cutoff for asymptomatic women. What I would say is contact us on the email, and we can provide you all of the information that we've got for asymptomatic women, and I can even send you our guidance, which we use for asymptomatic women, which can help you develop a kind of pathway for them. it's slightly different when you're talking about asymptomatic high risk women, because it depends whether they've got a transabdominal suture in place and all of that sort of thing. But do get in touch and I can send you our guidance and more information about that. I hope that's okay.
Thank you, Naomi. That's great. So the next question, did your trust have any resistance moving away from the NICE guidance?
Ours didn't. Our trust is quite unusual, and I appreciate that it's unusual in that we have quite a lot of preterm birth experts there. We're closely related to the university, so there's a lot of research which goes on around preterm birth. And I think that immediately when the NICE guidance first came out in 2015, our hospital site could immediately see that actually there was benefit in doing predictive tests in women under 30 weeks gestation. And there was benefit in triaging women, and we would actively do harm by admitting these women and giving them interventions. So we didn't experience any issues. I appreciate that's going to be different in different hospitals, but actually we did a survey where we asked 13 different hospital sites in the south of England. We asked them for their current guidance, and we looked at them compared to the NICE guidance. This was 2 years ago. And none of the 13 sites that we looked at were actually following NICE guidance. So I think a lot of hospital sites aren't following NICE guidance. And I know since then there's been some work from Angharad Care and others in Liverpool, and they've looked at what different hospital sites do. And I know that a lot of hospital sites don't follow NICE guidance. So no, we didn't, but I appreciate that might be different elsewhere.
Brilliant, thank you. Actually, a request has just come in, which is quite a nice one. So I'll move on with questions in a second. You were asking for feedback regarding the toolkit, and the request has just said, could the toolkit provide some case study examples of units where this is working successfully in order to shape our service around that best practice?
I'm writing that down, and I would definitely include that.
Thank you very much.
So
the next question, and you might have alluded to it actually in the presentation, is the QUIPP App a registered medical device?
Yes, I don't think I did allude to it, so that's a very good question. It is a registered medical device. It's a type 1 medical device registered with the MHRA, and it also has CE marking approval.
Brilliant, thank you. Next question. If I have a woman who came in and her risk score is 4.9%, do I have to send her home? No,
the QUIPP App definitely doesn't want to tell you what to do. So it actually doesn't matter what the woman's risk factor is. If you want to do something different as a clinician, please do that, and we don't want to tell you otherwise. I think people get a bit anxious when it comes to women who are near that cutoff, and that will change whatever the cutoff is. I think as soon as you get near a cutoff, people start getting a bit anxious. If you have a woman who's 4.9% and you want to admit her, please do. Likewise, if you have a woman who's 5.1% but you want to send her home, please do. I think what's important when you're looking after these women is that it doesn't have to be black and white, send her home or admit her. There are loads of different options that you could do in between. So it might be that you, I don't know, admit her for 4 hours, but that's purely for observation. So you're not giving her interventions, you're not giving her steroids, which we know could do harm, but you're just keeping her on the unit, keeping an eye on her just to see what happens. It might be that if you've got a coffee shop at the ground floor of your hospital, that you send her to go and get a coffee, just so you know that she's in the vicinity, you know, then to sort of come back up again in a couple of hours and check in with you. Whenever you send a woman home, you'd always say to that woman that if she continues having symptoms, to come back into the hospital unit, and that she can call you from home at any time. So it's not like you're sort of cutting off and severing all contact with her if you send her home. I think there's a lot of sort of grey areas that you can do with these women to make sure that you're providing care that you're happy with, but also making sure that you're safe in how you're practicing. And like how I was talking about with longer term prediction, if there's a woman who you're kind of not sure about, you can always send her home and invite her back to an antenatal clinic in a week's time, where you can, repeat these tests. So there are lots of things that you can do in between, which mean that you're not throwing the whole kitchen sink at her and giving her steroids and giving her everything, but you're just sort of practicing safely.
That's great, thank you. And I think we always say it's a good part of your jigsaw puzzle, but it's not the be-all and end-all. So I think that's great. So the next question on my list that's come up, how much data contributed to making the app?
Yeah, so for version 2 of the app, which is what we're on now, it's got more data added into it. So for the symptomatic arm, it's got just over 1,000 women's data into the app. And for the asymptomatic arm, it's got just over 1,800 women's data into it. So it's got a lot of women's data, which forms the different algorithms that we use for the QUIPP app.
Brilliant, thank you. So this is a question we get quite a lot, actually. Does the app store patient details?
No, it doesn't. So it's a good question, and yeah, I've been asked it a lot as well. So the QUIPP app is basically like a calculator. So it's not asking for patient details. It's not asking for the woman's hospital number or name or date of birth or anything. It's all anonymous. It's just like a calculator. You just input the information. So it definitely doesn't store anything. So you can be quite safe using it. That you're not, you know, we're not tracing any information about that patient. It's purely like a calculator.
Brilliant, thank you very much. So this question, actually, we get a lot from point of care departments as well. If we start using the app in our hospital, how should we document the QUIPP app score in the women's notes?
Very good question. And like everything, it depends on the hospital unit you're at. And every single place I talk to seems to do this differently. So some examples, where I work, when you're assessing a woman in threatened preterm labour, a bit like when you're doing any triage assessment, obviously as a clinician, you'd be writing her medical history and her background. Then we'd use a QUIPP app, and we'd normally just write QUIPP app risk within 1 week is X%. We found that from a kind of clinical risk and governance point of view, that if you then went back to those hospital notes in a year or so's time, because you've written your clinical triage and assessment notes before you've used the QUIPP app, you'd then be able to see her risk factors. So it's very easy for someone to look at your triage assessment, know the woman's risk factors, input them in the app and get the same result that you've just got. So we find that works well. Other sites have started using stickers where they'll write the woman's history up, and then when they're using the QUIPP app, they'll take one of these stickers, put it in the notes, and then just write in the score on the sticker. As a result of that, we're actually including or going to include stickers that you'll be able to print on the next version of the QUIPP app toolkit, so they'll be available from next month if that's something you want to use. If your hospital uses electronic hospital notes, you can ask your local maternity system provider to input a section where you can easily type what the QUIPP app is. So whether you use Badgernet or Euroking or E3 or whatever, you can ask them for your local unit if you could input something on the triage section so you can easily type it in. Other sites have asked that their clinicians use the website version of the app, screenshot the result, and then attach that to the woman's electronic hospital records. So basically everyone does something different. We, as the QUIPP app toolkit group, don't mind how you do it. We don't have any rules or regulations on what you do. That's something which is purely down to you and your individual unit.
Brilliant. Thank you for that comprehensive answer. There's obviously so many different options available. So I've got one last question as it stands here. So it is, the QUIPP app asks if the woman has had previous cervical surgery. Does that include punch biopsy?
No. So that question is basically looking at quite significant cervical surgery. So it's including things like large loop excision of the transformation zone, laser treatments, or cone biopsies. It is quite difficult to remember what it includes and what it doesn't include. If you forget in 6 months' time, if you're like me and your memory is like a goldfish, it's really easy to go on the QUIPP app, and then there's the information section on the QUIPP app. Remember at the bottom how there was symptomatic, asymptomatic, and then information. click on that and it will tell you exactly what the different fields include, don't include. So, you know, you can always double check there.
That's absolutely brilliant, Naomi. That actually concludes the question and answer section. Nothing else has come in. And I'd just like to say thank you so much for your time this evening. I think it's been very beneficial for everybody on here. And I'm just going to share my screen one last time, and then everyone can just see the email addresses again, just in case anybody has got any questions that we haven't answered for you today. Don't hesitate to get in touch with either the Hologic team or with the QUIPP team directly. So thank you ever so much for everybody and your time, and I hope you have a good evening.
Thanks. Have a good evening. Bye.